So my name's Jo Rycroft-Malone. I'm the Executive Dean for the Faculty of Health and Medicine at Lancaster University, but I also have the great privilege of chairing the Northwest Coastal ARC Stroke Roundtable, which is focused on improving stroke services and outcomes for people in the Northwest Coastal area. And on that group, I have the great pleasure of working with Deb. So Deb, please tell people who you are and what your role is.
Thank you, Jo, and thank you for the invitation to speak with you this morning. So I am a stroke doctor at my core. So I've been a doctor in the NHS for the last 25 years, working within Cheshire and Merseyside. And I am also, for the last 2.5 years, been working as a National Clinical Director for Stroke Medicine with NHS England. Before that, I worked predominantly in a stroke improvement role as the Getting It Right First Time National Clinical Lead. I'm in partnership with a colleague, David Hargroves, who works in the South East. And before that, I got an appetite for quality improvement by working as initially the Cheshire and Mersey Strategic Clinical Network Clinical Lead from 2013, and then that role expanded to covering Lancs and South Cumbria. So yeah, wide portfolio, but essentially stroke doctor at heart and quality improver in my blood.
So a great question to start then, given your experience and the roles that you have, it is very much about what, why is stroke a priority? I think thinking about that on a national level,
Sure.
but also specifically in relation to the Northwest Coast.
So stroke is the largest cause of adult disability in England, with we've got over 1 million stroke survivors living with physical, cognitive, emotional burdens of stroke, and it's the 4th highest cause of death. We know it costs health and social care £26 billion a year, and that's expected to rise by 2035 to 91 billion. That means we're going to have a doubling of stroke survivors, 60% increase in the number of strokes. And if we don't do something differently to improve our services and outcomes, that's going to be a massive public health crisis, really. We know that the public generally don't understand stroke. 9 out of 10 people don't understand the risk factors for stroke, and that most of them are actually modifiable in terms of health, healthier living and blood pressure control, cholesterol control. So we've got a real imperative to do things a little bit differently. I think as well, and why it's important for me across the Northwest is with our new operating models. So we've got our new 42 integrated care systems, or ICSs. We know that out of those 42, the 3 ICSs in the Northwest are within the top 10 most deprived areas. And we know that being in deprived areas increases the risk of stroke and health inequality, specifically, and the risk for cerebrovascular disease, which obviously includes heart attack and stroke. So from a personal perspective, being a Wigan girl, and so being a very much focus within the Northwest over my professional and personal career, then we have to, in the Northwest, have a real laser sharp focus on health inequalities, cerebrovascular disease prevention, and specifically stroke.
So I think it would be really useful to hear from you about some of the regional and national initiatives potentially that we can think about in terms of the Northwest Coast.
Okay, so I mean, what's going on nationally? We are very lucky, and it does feel like a privileged position for me as a National Clinical Director to be in, that stroke is one of the NHS England long-term plan priorities. So that was published in 2019 with a roadmap for the decade of prioritisation of delivery of care and services. So as a clinical priority, we've got really ambitious targets around prevention, treatment, rehabilitation, life after stroke. And as part of that, we've got a national stroke programme that is supported by the Clinical Policy Unit, and its senior responsible officer is Steve Powers, who's the medical director for NHS England, and he's really passionate and supportive around how we improve stroke care. That National Stroke Programme supported the formation of 20 integrated stroke delivery networks across the country, with clinical leadership across acute and rehabilitation as well, and programme leadership and management. And that's given us a clear governance structure and accountability and reporting structure to actually drive forward quality improvements. The structure that we're doing that under has been via the publication of the National Stroke Service Model in 2021, and subsequently the Integrated Community Stroke Service Model earlier this year in 2022. And we've also formed a national stroke board that I co-chair with Juliette Bouverie as the chair, the chief executive of the Stroke Association. So having that really key third sector charity partnership working has been vital to the work that we've done. And within that board, we've got really key work streams that are very focused on urgent emergency care, which includes our pre-hospital work, rehabilitation and life after stroke. Prevention is obviously a cross-cutting theme across all of the cerebrovascular and respiratory disease pathways, but is a key focus, especially with our health inequalities lens. And then finally, we have a key work stream across data finance and research. So as a programme, one of the first pieces of work I led on with NHS Innovation and Research was a demand signalling programme that we've worked really closely with the Stroke Association, James Lind Alliance Priority Setting Partnership. So from a policy perspective, patient, clinician and academic pathway, we have everything laid out in terms of where are the gaps in evidence that we need to drive policy decisions, where are the gaps from a patient, public voice perspective, and with an academic lens, what do we need to prioritise our quality improvement, research and academic focus on?
Yeah, so you've laid out a really clear sort of framing of what's going on nationally and what therefore can help us regionally. So just thinking about the stroke roundtable specifically, it'd be really interesting to hear from you what you think being part of the stroke roundtable can offer ARC member organisations.
Well, I think it's a really good opportunity to bring people together that wouldn't normally in any other forum necessarily sit in whether a real room or with our new ways of working, a virtual room. I think the virtual working that we've all seen accelerate over the last couple of years has been perfect for this sort of collaborative working. I think it's only when you're aware of some of the policy directions and strategic directions across health improvement that it becomes very clear where the gaps are that we need to fill with our increased expanded knowledge base. And those gaps in evidence, we also need to know and have the links, the key relationships with people about how we influence policymakers, research funders, how we bring our clinicians on board in terms of them prioritising some of the key service improvements that we need to look at, but also how we hear from people that we wouldn't necessarily normally hear from in our day-to-day work and life. So that's what's really quite nice and unique, I think, about the this roundtable. I'm also particularly excited about it because it gives a key focus on us as a Northwest region. We're very diverse. We've got a few major cities and metropolis configurations, but we've also got massive geographical challenges. With certainly specifically within Lancaster South Cumbria. So us having a focus on how we deliver the best care, irrespective of whether you live in inner city Salford or in the far reaches of the Lake District is really, really important.
That's really helpful to hear, and that idea of bringing different perspectives together that wouldn't normally be the case is obviously a clear strength. And I'm just wondering if there are also some advantages from a strategic point of view as well by bringing those voices and perspectives together.
I would say that there definitely is. You know, over the last 15 years or more working from a quality improvement perspective, I've worked at local, regional, national level, and the number of times that a huge amount of work and time is put into a project or an offer only to get to the strategic planning point and it doesn't tick the boxes for what either commissioners, providers, research funders are looking for. So having that really early democracy of ideas is really, really important. And I think also the key relationships between hearing, if we put our patients at the centre of everything we do, so hearing from our stroke survivors, providers, commissioners, clinicians, researchers, academics, innovators, right at the beginning of our concept, storming and norming discussions, often is a real time saver further down the line, and I think enables us to just have those light bulb moments that we wouldn't necessarily have if we didn't have such a diverse group of people. But the key thing being that whilst we're all diverse, we've all got one key disease entity in our hearts that we're focusing on, and that's really unusual.
And from my point of view, from a chairing point of view, what's really, I think, really valuable in that conversation is very grounded in the experience of patients and the public, those with lived experience.
That's that is so important. And I think what was good from the not only the demand signalling work that we ran within NHS England Research, but also the James Lind Alliance priority setting partnership is both of those processes that ran in parallel were utterly patient-centred and really heavily relied on patient voice and patient experience and that lived experience.
So given in all the roles that you have and have had, and you'll have seen a lot of change and a lot of development during that time, and of course now as well, could you say a little bit about what you think we could learn from in terms of system change that we might be able to think about in the northwest coastal area around stroke?
So I think it's interesting. Someone asked me about system working a few weeks ago, and I thought, oh gosh, what do we mean by system working? And I think system working means different things to different people, but working across different organisations is absolutely pivotal to the success and to effective change management. We're all really pushed for time and our workforce is more stretched than ever. So being really efficient and effective and focused on how we spend our hours each day is really important. I think as part of that, it means that we need to understand the systems that we're working in. And an example I would give is obviously in the GIRFT leadership role, we met with every single stroke team across the country over a 2-year period. And I thought I knew what the problems were and the challenges in delivering effective stroke care. And I knew some of them, but there were so many more that I didn't know that I learned from actually meeting people. And although our workforce, I think, is our greatest asset, it's also our greatest risk. So looking after our workforce and enabling compassionate distributed models of leadership within our networks is a real key passion of mine, I think, across our system working. Because I think if we, as a roundtable, are looking at our workforce and how we are creative and innovative, but also support every person to feel enabled and encouraged and capable to actually work within their team and with others to improve services, then we've hit the nail on the head, haven't we? And that's, I think, easier said than done, but that focusing on our workforce, focusing on our leadership models across the system is vital.
Yeah, I completely agree. And then just I think a final question really, which is looking to the future and the role of the group in that, in terms of being able to the role of the group in enabling sort of complementarity, lack of duplication, but also in thinking about that vital piece that you mentioned earlier around the sort of future research agenda. So I'd just be interested to hear what you might have to say about that.
Well, by having again the right people around the table that are aware of policy evidence gaps, but also gaps from a patient public voice and academic and research perspective is so important. Again, going back to not reinventing the wheel, a huge amount of resources obviously been put into these priority setting partnerships. So from a pure research perspective, I think using those two key documents together to, as a research network, say, what are we going to focus on? We've got the ear of research funders. We're working really collaboratively, obviously, with the Stroke Association, and it's great that we've got a Stroke Association representation within the Roundtable. I think that it's important to look at what we've got already, knowing that we've got there's an appetite for looking at this really important disease profile, and also using the relationships that are built through the Roundtable. So, you know, for example, within my role, I have an ear for within the NIHR and others. Obviously, Caroline Watkins is a huge important figure within stroke research. Not just, and I think bringing in that multidisciplinary element is absolutely vital, but also I think a really key part is looking at the more pragmatic clinical consensus that we need across research priorities and bringing our clinical community with us when we go forward. And as a final point, any research that we do, making sure that we've got the public and patient voice at the centre of that, because we all know our research will go nowhere if we've not got that level of backing and support. So I think the stars have aligned really for us to, within the Northwest, make sure that we're time efficient, we've got a shared vision across our research direction in the future, but also that we've got a few key policy documents and research documents that mean that we're not on a whim deciding the direction of travel here. We're following a well-described prioritisation pathway.
And a good note to end on, I think, in terms of the point you make about making sure that whatever research we are doing, we're thinking really early on in the process about how we get that research into practice by working together with key partners, which is essentially what the group is about, isn't it? That's the essence of the group.
Absolutely.
Yeah. That's been great, Deb. Thank you so much. Really appreciate your time, and look forward to seeing you soon and the next Roundtable.
That's great, Jo. Thank you so much for your time. Bye-bye.